Go ahead and call the subcommittee meeting to order. Today, the subcommittee meets to continue our discussions on the military health care system to help inform our efforts to reform military health care. I know the timing of our hearing is a little unusual for the military personnel subcommittee. I appreciate everyone's participation even at this late hour. Just too much to get done and not enough time to get it done in. The Defense Health Agency was established in October 2013 to manage the activities of the military health system, which includes integrating clinical and business processes across DoD and the military services. A key element was establishing shared services to eliminate the need for each of the military medical services to manage functions that are common across the MHS. At the time the DHA stood up, DoD estimated that the shared services would generate significant savings by eliminating redundancy and variability. I'm interested in hearing how much the DHA has saved the DoD since 2013. I'm also interested in hearing about the DHA's role in medical readiness, and in particular how the DHA assists the Army, Navy, and Air Force medical services to provide a medically ready force and ready medical personnel to combatant commands. In the FY17 budget, the Department of Defense has proposed several measures aimed at reducing the cost of the Defense Health Program by reforming Tricare. While I appreciate the Department's efforts to simplify the health benefit, the proposals still shift the cost burden through Tricare fee and cost share increases to our active duty family members and our retirees. What is not clear from the Department's proposals is how this reform addresses the concerns we have heard from our beneficiaries. Does it improve access to care and reduce the hassles of the referral process? Will the anticipated savings generated by the reforms be used to improve the beneficiary's experience? Lastly, I'm interested to hear your views on the MHS structure and function, especially as it compares and contrasts with civilian hospital systems. I hope that our witnesses will address these important issues as directly as possible in their oral statements and in response to member questions. Before I introduce our panel, I'd like to offer our ranking member, Ms. Davis from California, an opportunity to make her opening remarks.
Thank you, Mr. Chairman. I also want to welcome our witnesses, especially Admiral Bono. I believe that this is your first hearing before our subcommittee in this capacity. And Dr. Woodson, I hope that this will certainly not be the last time we are able to hear from you this year, and I look forward to working with you on these reform efforts, and I know that you've worked very hard on this for quite some time. The committee has held several roundtables and hearings over the past several months to try and better understand the military health system, and our goal is to find the most appropriate way to reform the military healthcare benefit in order to provide the best, the most cost-effective benefit, while maintaining, of course, the appropriate level of medical readiness for the force. Your written statement details the initiatives that you have taken on your own, as well as the legislative reform proposals that you have submitted once again for our review. And I look forward to discussing how we can move forward together to continue to provide access to quality health care for your beneficiaries, as well as ready and capable providers to care for our force. Thank you very much, Mr. Chairman, and I know we have a number of objectives with this hearing today, and I hope that we're able to move through those. Thank you.
Thank you, Ms. Davis. I would respectfully remind the witnesses that we desire that you to summarize to the greatest extent possible the high points of your written testimony in 5 minutes. As a reminder, you see the lighting system in front of you. At 4 minutes gone, it'll turn yellow, and when your time is up, it will turn red. At this time, without objection, I ask unanimous consent that additional statements from the Fleet Reserve Association and the Military Coalition be included in the record of this hearing. Without objection, so ordered. Let me welcome the panel. I'm pleased again to welcome back the Honorable Dr. Johnathan Woodson, Assistant Secretary of Defense for Health Affairs, and for the first time welcoming Vice Admiral Raquel Bono, Medical Corps United States Navy Director of the Defense Health Agency. With that, Dr. Woodson, you're recognized for 5 minutes.
Thank you very much. Chairman Heck, Ranking Member Davis, members of the committee, thank you for placing the issue of military health system reform high on your agenda for 2016. The military health system takes great pride in its performance in combat medicine over the last 14 years, with a greater than 95% survival rates for those wounded in battle. Our ability to prevent disease through exceptional primary care and preventive medicine services produced equally historic outcomes in reduction of disease and non-battle injuries. The challenges we face in medicine and national security, however, continue to evolve and require new approaches so that we are prepared for the future. We have undertaken a number of initiatives to strengthen the military health system in all facets of its responsibilities, and they have been organized around 6 principal lines of effort, which we have spoken about in previous testimony. I was therefore encouraged that last year's Military Compensation and Retirement Modernization Commission reviewed and supported many of the initiatives that we had already set in motion in the department. Let me briefly describe those efforts. First, we have modernized our management system with an enterprise focus. We established a Defense Health Agency that Vice Admiral Bono leads. The agency is entrusted with providing common business processes and standards in support of the military departments and the combatant commanders, an approach that provides greater operational efficiency and ensures joint solutions to our customers. We identified multi-service markets and developed 5-year business plans to promote common solutions and optimize the use of the military treatment facilities while providing required care to beneficiaries in the purchased care sector. In addition, we've acquired and are now preparing to deploy a new electronic health record using commercial off-the-shelf products. Together with the Surgeons General and Vice Admiral Bono, we have established an enterprise-wide dashboard to actively manage our performance in readiness, access to care, quality, safety, patient satisfaction, and costs. The Defense Health Agency achieved the milestone of full operating capability on 1 October 2015, and in its first 2 years saved over $700 million. Second, we are defining and delivering the medical capabilities and manpower needed in the 21st century. With the services, the Department has embarked upon a thorough process to define essential medical capabilities and metrics to monitor readiness. Third, as a result of the modernization study, we have analyzed infrastructure needs and right-sized several military treatment facilities, as well as made adjustments to move skilled medical personnel to markets where the MTFs can recapture care, they can maintain their skills, and reduce overall costs. The fourth line of effort is perhaps the main focus of today's discussion. That is our plan for reforming Tricare. We are appreciative of the input from the beneficiaries and the service organizations that in recent testimony have expressed their support for Tricare. The Tricare benefit was named the #1 health plan in the country for customer experience by Temkin in 2015, owing in no small part to the comprehensive coverage and low cost to the beneficiaries. But we also heard loud and clear from our beneficiaries that access to both primary and specialty care needs attention, particularly in the MTFs. In response, we've implemented a number of access improvements last year to open up appointments and resolve appointment issues on the first call. We are improving access to after-hours care, particularly child care, whether that is through evening clinics, weekend clinics, the ability to email providers with questions through secure messaging, the availability of a 24/7 nurse advice line that is integrated into our appointment system, streamlining the referral process, and implementing urgent care demonstration programs that Congress requested in last year's Defense Authorization Act. Our T-2017 contract, which will be awarded in 2016, includes provisions that further improve upon the experience of care for our beneficiaries. The PB-17 proposal provides choice and incorporates the feedback of our stakeholder groups. The fifth line of effort has been to expand the strategic partnerships with the civilian health organizations to enhance our ability to meet and exceed our responsibilities in readiness, quality, safety, and satisfaction. Partnerships with the organizations such as the American College of Surgeons and the Institute for Healthcare Improvement are providing tangible benefits that offer us ways to sustain our trauma system, improve clinical quality, and become a high reliability organization. Finally, the sixth line of effort is about the global health engagement, where DoD is deeply engaged with other partners in reducing threats posed by emerging infectious diseases and building bridges through healthcare around the world. We have contributed to surveillance, prevention, diagnosis, and treatment strategies to combat well-known outbreaks of Ebola and now Zika, as well as ongoing efforts to prevent outbreaks in other areas. We enter 2016 confident that the reforms in the MHS and health benefit can be further strengthened through a combination of legislative and operational reforms. I am grateful for this opportunity to be here today and look forward to your questions.
Chairman Heck, Ranking Member Davis, and members of the subcommittee, thank you for the opportunity to appear here today. I am pleased to represent the Defense Health Agency and explain how the DHA is contributing to the modernization of the military health system. In November, I was honored to become the Defense Health Agency's second director. Only a month earlier, the agency had reached full operating capability. After 2 years of collaborative work with Army, Navy, Air Force medical leaders, and the Joint Chiefs of Staff that established the concept of operations for many of the functions of the agency. Our responsibilities center on supporting the military departments and the combatant commanders in the execution of their missions. The Defense Health Agency was created in the recognition that most healthcare delivery is common across the Army, Navy, and Air Force. What we need, what we buy, and what a best practice entails in both the clinical and administrative environments. The Defense Health Agency helps bring together common support functions into a new enterprise-focused organizational structure. We are able to help Dr. Woodson and the Surgeons General see and manage across the MHS in a more unified way. One of the principal ways in which we deliver this support is through the operation of shared services. Critical enterprise support activities include Tricare, pharmacy operations, health information technology, medical logistics, public health, medical R&D, education and training, health facilities, contracting, and budget resource management. In addition to the 10 shared services that have been implemented, the DHA has also brought in joint activities that had previously been distributed to the services that acted as executive agencies. These include the Armed Forces Health Surveillance Center, the Armed Forces Medical Examiner System, the DoD Medical Examination Review Board, the Defense Center of Excellence for Psychological Health and Traumatic Brain Injury, and the National Museum of Health and Medicine. The DHA offers value, however, to more than our COCOMs and services. We serve as a single point of contact for many intra-agency, interagency, and external industry matters, simplifying the process for our partners and outside colleagues to work with the Department of Defense in support of a number of our imperatives: research, global health engagement, adoption of emerging technologies, healthcare interoperability, and more. The existence of the DHA has streamlined engagement with the Defense Logistics Agency, Defense Information Systems Agency, and other field agencies. External to the department, the DHA provides a single point of contact for operational matters with the VA, a number of agencies within HHS, to include the Centers for Medicare and Medicaid Services, the Food and Drug Administration, the Centers for Disease Control and Prevention, the Public Health Service, and more. We have successfully collaborated with the Justice Department on the prosecution of healthcare fraud cases, most recently with highly suspect activities around compound medications. We work with Treasury, State, and the GSA on a number of critical functions that directly support our healthcare mission. I would like to focus on one shared service in particular, the operation of Tricare, the military's health plan. Tricare modernization is part of the MHS modernization plan that Dr. Woodson just outlined. We have a number of Tricare initiatives already underway in 2016. Later this year, we will award the next round of Tricare contracts known as T2017, which is when healthcare will become operational under the new contracts. We are simplifying the contracts, reducing management overhead in both government and contractor headquarters by moving from 3 regions to 2 regions. We are expanding the means by which we manage the quality of our networks to ensure that they meet the expectations for quality and safety that we expect for our beneficiaries, whether in the direct care system or in private sector networks. We also will introduce innovative models for value-based purchasing in the coming year. My staff, in close collaboration with the services, is also crafting the contract amendments to permit Tricare enrollees to use urgent care centers without pre-authorizations. And our analytics team provides the department's civilian, military, and medical leadership at the headquarters and field level with the ability to assess the enterprise-wide performance of the military health system using agreed-upon joint measures for readiness, health, quality, safety, satisfaction, and cost. The DHA is now an integral and integrated part of the military health system. We are proud to contribute to the modernization of this system through a joint collaborative solution and responsible management approach. I'm honored to represent the men and women of the Defense Health Agency, and I look forward to answering any questions you may have.
I thank you both for your testimony. So my first question is, how does DHA relate to and interact with the service surgeons generals in carrying out shared services and in the relationship of facility management, staffing of facilities, and things along those lines?
Thanks for that question. And there are two parts, of course, to the revised enterprise management scheme, if you will, that we've outlined and carried out over the last few years. So first is the Defense Health Agency that has the 10 shared services. And so in regards to your question about facilities, the Defense Health Agency provides the common business processes for managing those facilities. As it relates to governance and how the DHA interacts with the services, there's a governance system that's made up of medical operations group and, most importantly, the medical deputies advisory group, which looks at the enterprise priorities and helps set those priorities with Admiral Bono.
So then, can you provide some examples of how DHA has achieved integration of clinical and business processes at the MTFs across the services, and what are the additional opportunities for expanding common activities and functions across the MTFs?
So maybe I'll start, and then certainly Admiral Bono will want to chime in. I think the biggest example is in health information technology. Prior to the DHA, separate activities in the three services. A lot of money goes into health IT, whether it's in DOD or it's in any private health system. Bringing it into enterprise focus, you can reduce the redundancy. You can actually develop the enterprise tool. I don't think we could field a new electronic health record without an enterprise focus on health IT. It's allowing us to make changes in the network at lower costs that will save billions of dollars going into the future.
A couple of additional areas then would also be in pharmacy, where jointly working with the services, we can create a uniform formulary that makes that available to all of our patients. We can also, through this pharmacy shared services and working with the military services, have been able to move to almost 100% electronic order entry, not only within the MTFs, but from our providers or from providers that are seen out in the network, out in the civilian world. One other area is in medical logistics, in ordering the equipment that we use in the MTFs and what we use even downrange. So being able to collaborate and consolidate some of those purchases has saved us money, as well as created less variability or more standardization in the acquisition of those products.
So is all purchasing for durable equipment then purchased through DHA for the individual MTFs, or is there a blanket purchase order that an MTF can buy off of at DHA negotiated rates?
Yes, sir. We work very closely with the Defense Logistics Agency, and so they've created an e-catalog which contains all that, and all MTFs can order off of that catalog.
My next question is probably going to take longer to answer than 1:30, so I'm going to yield back my time and wait for the second round and recognize the ranking member.
Thank you, Mr. Chairman. And I think we all recognize there are a lot of layers to this. And at the same time, I think you've made an attempt to simplify the proposals from what we had seen initially. And I'm very pleased to see that. I think that's great. But I'm also wondering, as we boil it down a little bit, I think the chairman mentioned earlier about shifting the cost and the perception, at least, and the reality for some, that there is a shifting of costs from DOD to the beneficiary. So I wanted to, I guess to just echo perhaps what constituents might be asking. I'm paying more for my health care, but what do I get in return?
Well, that's a great question. And so let me see if I can explain this from a number of perspectives. PB17 really offers a simpler system. We've boiled down a lot of different programs into basically a managed care variety, which is the HMO variety, and a self-managed, which is a preferred provider organization variety, or fee-for-service, which is the ability to go anywhere, anytime to receive health care. The issue brings into sharp focus, then it gives choice, because if you want to use the PPO product or the fee-for-service product, you have the ability to go and you see physicians that you want when you want to see them. And particularly with the PPO product, no longer are you paying a percentage of the fee, but you're paying a fixed amount, so you can predict your cost better. We did the analysis, let's say, for a family of 4. The actual rise in total out-of-pocket cost rises from about 8% to about 10.4%. And this needs to be seen in the context of when Tricare was originally put forth, where the cost share was 27%. So it modestly increases that cost, but it gives greater freedom. And of course, with the PPO product, the referrals go away, which was a major dissatisfier for many of our constituents. There's no change for active duty. There is this participation fee, but again, because we've moved to a fixed copay, the actual increase in out-of-pocket expenses is only from about 8% to 10.4%. Notably also is that our catastrophic caps are low. So your expenses will accrue against your catastrophic cap. And the issue really is that this is a major benefit of Tricare versus other commercial products where the catastrophic cap is much higher. So although there's a slight rise in that catastrophic cap, remember those caps were reduced back in 2001 and have not risen over a decade and nearly a half. There's also the second payer option that we've put forward, which lowers the fees for those who have other health insurance. We've also set the fee structure so that it incentivizes for those who are around MTFs really to receive care at very low cost and no cost if they receive care in the MTFs. So I think there's great value there. There is a very modest increase in costs, again, to this average family of 4, but it's in the context of having had a diminished cost share that has progressively gone down over the years.
I don't know, Admiral Bono, if you want, I actually wanted to sort of throw something else in there about a FEHBP option that might be along a continuum in terms of what people could look at. I would suspect that would only be for people who would choose to have increased costs that would, have a higher share of that option, but it would be possibly part of a continuum, and I think that's some folks have thought about that a little bit. We'll probably have a chance to get into that in terms of whether you think that would be a good idea or not, but it certainly would continue to do that. I think that my time is up, but I wanted to I think what you have to say is very helpful. I think we also have to find ways of doing it in a quicker elevator speech so that people have an understanding immediately of what it means to their family. And maybe that additional percentage is the best way to talk about that. But I know that there's a lot of concern out there that nevertheless, people are going to be paying a little bit more. And when you think in terms of the benefit, they want to know that they're really getting something for that. So, thank you.
Mr. Knight.
Thank you, Mr. Chair. So I just have a couple questions on kind of the timing of this. I know this was established in 2013 that you, can you give me an idea of what happened before that, why we've had these problems, why it's taken a little bit long to figure out these problems, and because we're doing this kind of this purchasing power of getting the 3 services to work together, are there any audits that are going out there that we can figure out if this is actually everything that we can do or if there's other issues that we can handle?
So part of the evolution of the DHA was when we identified these shared services, which were brought together and designed by the services, and the conditions for success were identified, or successful performance was identified there. What we realized was in bringing the services together that in many times we each had different business processes to accomplish similar end goals. And so being able to standardize that and understand what nuances or what specific service concerns were being addressed took some time to do that. In addition, as we brought people together, we also had to understand what our own infrastructure had available to support some of this. And so it's been an adjustment, but we've been able to watch that and look at it. I think at FOC now, full operating capability, we now have the ability after 2 years of actually measuring what our baseline performance is and now being able to measure our progress towards goal. So I think that was probably the primary issue in standing up the DHA, was bringing 3 services with different business processes.
Do either of you believe that this might be a model to move forward with other services that the branches are doing, that maybe at some point they're going in 3 different directions, and they have to go in 3 different directions in certain aspects because they do certain missions, but in other missions they don't, because you know, a hurt soldier is the same as a hurt Marine or sailor. So could we use this as a model to help in other situations in the military?
So the short answer is yes. If you look at medical, as you've suggested in your statement, 85% of what the services do in regards to delivering care is alike. As a surgeon, I always say that the outcomes you want when you do a procedure, the resources you bring to having to do that procedure, the standards you want to apply are all the same, no matter whether you're wearing an Army uniform, a Navy uniform, or an Air Force uniform. So 85% is alike. And that relates to the operational environment as well as the garrison environment. There is that 15%, which is service unique. So what Navy brings to float platforms and undersea medicine, what Air Force brings to aerial platforms, needs to be respected because they've made great advances, and what Army brings to land-based projection of force. But the majority is alike, and so that's the underlying concept. And I would remind the committee members that prior to the DHA establishment, we had 19 studies that suggested that we needed to come together. And when we conducted the task force back in 2011, it was pretty clear that we could achieve economies of scale and efficiencies. And so I think the issue is that we really have delivered on that at this point.
Thank you. Thank you, Mr. Chair. I yield back.
Thank you, Mr. Chairman. Dr. Woodson, what do we know about available or excess capacity at military treatment facilities since this proposal would drive more customer use? Maybe I'll just start there and then might have some other questions based on your answer.
Great question. So we need to look at it in 2 ways: outpatient capacity and inpatient capacity. Inpatient capacity, we clearly have excess capacity, particularly in many specialty areas, and we need to be able to utilize the MTFs more effectively. In the outpatient, as in true throughout the country, there is a less of a capacity in primary care. However, having said that, we've done analysis through the modernization study, and we do have a significant capacity there, particularly if we drive up productivity, if we increase panel size, if we create capacity by use of telehealth and other mechanisms to interface with patients who don't require a face-to-face appointment, and just better management strategy. So there is capacity there.
And do you have you measured that capacity? And is that a number that you have at the top of your head or one that you could get to the committee?
So I can get that to you, and I would rather take that for the record in terms of numbers, but let me just tell you that we conducted this modernization study which looked at just that. So I think we do have substantial data.
Okay. And then if I heard you correctly, part of the capacity will be developed by forcing efficiencies and modernization, or were you saying that that has already happened and has created the capacity?
So that's in progress, and as I mentioned in my opening statement, things like secure messaging, streamlining the referral process, increasing panel size, urgent care, things that increase our ability, weekend and night clinics, preschool clinics for children. All of these things increase your capacity. So we're carrying out those reforms as we speak.
Great. So when you provide those numbers for the committee, I'd love to know what established capacity we have, and then the capacity we project forward if we're able to follow through on these great initiatives that you talk about. So one of the concerns that I hope your numbers will answer is whether there's any threat to current service members, active duty service members receiving care at military treatment facilities in terms of compromising capacity for their priorities and their care. And then I have another question related to that.
So I don't believe there will be any compromise to service
because the
active
capacity
duties.
exists. Great. And then the other question, Admiral Bono brought up, care for veterans. Does the capacity then also exist to complement care provided at the VA, where you have unacceptable wait times, especially in specialties like behavioral health and mental health? And should we avail ourselves of that capacity within military treatment facilities for veterans who may not be Tricare beneficiaries?
So the short answer to that is yes. The longer answer is that we already have a number of sharing agreements with the VA around the country. And the issue really needs to be analyzed on a local level because all of the markets are different. And the capacity to take care of particularly behavioral health individuals will be somewhat market dependent. So the short answer is yes, but the more involved answer, and we've got data to look at the distribution of the facilities and what's available in each market.
Great. I look forward to seeing that, and to the degree that you can localize that capacity. I'd love to know, for example, we in Beaumont Army Medical Center and El Paso at Bliss, what we have and what we project going forward. And maybe other members would like to know that for their districts as well. Thank you very much. I yield back.
Thank you, Mr. Chairman, and thank you to the panelists for testifying today and for your service. I wanted to direct my question to Admiral Bono. I want to discuss the General Temporary Military Contingency Adjustment Program, which, as you know, exists to offset the lower reimbursement levels provided under the Medicare payment model to sole community hospitals that provide care to large volumes of service members and military families. In my district, Fort Drum does not have a full MTF on post, so soldiers and their families depend on community hospitals, one of which is the Carthage Area Hospital. Outpatient services to our military and their families represent anywhere from 30 to 35% of this hospital's outpatient services. And unfortunately, Carthage is still being reimbursed at the Medicare levels. And although they have applied, they have not received relief from the General Temporary Military Contingency Adjustment Program. And this appeals process has been going on for 2 years, since September of 2013. So my question is, what is DHA doing to alleviate these bureaucratic challenges facing facilities like Carthage Area Hospital?
Thank you for the opportunity. I'll confess that something like that is something I'm still getting a better understanding. But your broader question about what DHA is doing to address some of these bureaucratic or these administrative challenges is something that I'm taking into real strong consideration as we're going forward in the modernization of our healthcare plan. In looking and in arriving at the DHA, one of the first things that I realized is that many times we have policies or operations in place that need to be brought into a more modern approach, to be a little bit more agile and to look at some of the processes we're doing. This was particularly evident with some of our referral management operations and our processes there. So I'd like to take that for the record and look at it a little bit more closely so that I can better understand where the opportunities are. But I share your concern on that, that administratively, part of what I feel my responsibility to do is to make sure that the DHA is looking at our administrative processes and streamlining them to the best of our ability.
Great, I appreciate that, and I look forward to working with you to alleviate those bureaucratic challenges. But I'd also like you to take for the record the specific case of Carthage Area Hospital, the uncertainty for 2 years since September of 2013. We are working with their office. We are trying to work with DHA, and we need to get more understanding of the decision, which brings me to my next point. What actions have been taken to ensure that these reimbursement levels are determined in a transparent manner? So bringing more transparency to the decision-making process. Have you put any thought into that from your position?
I have, as a matter of fact, and I realize that being able to be more transparent is helpful to everybody. So you will see that in many of our discussions, that we're bringing that to the table, being more transparent about our conversations, being more transparent about our analysis as well.
Okay, great. I think that bringing greater transparency would not only help this specific case of Carthage Area Hospital, but in terms of who qualifies for this program, because there's been an independent audit of Carthage that basically says that they are beyond the 10% requirement, that outpatient services make up 30 to 35%, so they should qualify for this program. So we need transparency and clarification, and I'm sure this isn't the only hospital that's facing this issue. And I yield back the rest of my time.
Thank you, Mr. Chairman. I applaud you for thinking through how to simplify the Tricare plans, and I think the intended move to an HMO and a PPO makes some sense. But the PPO, which is where I want to focus, still relies on your current networks. And as I read, and I just read it again last week, the Military Compensation and Retirement Modernization Commission's overall assessment, they were pretty critical of the adequacy of the provider networks within the Tricare system. So I want to get into the weeds on this a little bit, but for starters, I'd like to ask if you agree with their assessment of your networks, and if not, where do you differ? And maybe I'll start with you, Mr. Secretary.
Thank you very much for that question. And I don't agree with the assessment that the Commission made about the adequacy of the network. There were several things I think that they considered in making that assessment. So first of all, let's start with some big numbers. We have 424,000 physicians in the Tricare network, and we've got virtually all of the 5,000 hospitals that are available to take care of our patients. But the issue is that some of the assessments that were made relative to, let's say, the Fort Bragg or the Fayetteville area didn't take into account that when we consider the network development, we consider what's available in the MTF as well as what is required. So we have formulas that we use for trying to decide the adequacy of the network. And the issue is that you may not need as many orthopedic surgeons in your network if you've got a lot of orthopedic surgeons in the MTF, particularly in that 30-mile area around the MTFs. You know, there are some other formulas that every insurance company uses to determine adequacy. It turns out that the average insurance company will have a ratio of particularly primary care providers to population of about 1 to 528. Tricare's is 1 to 24.
If I can stop you there, though, because it's an interesting comparison. The difference is when you're talking about private insurers, if they're wrong, if their formula might be right overall, but in particular communities around the country there are gaps, their beneficiaries can walk, and they can go to a different insurer, a different plan, and remedy their own situation. The difficulty is under Tricare, that remedy doesn't exist. So let me just finish. My question then, because I've only got another moment to try to unpack this. If we made the networks in the FEHBP available, to our military personnel, what would that do, in your opinion? Pro and con, what would that do?
So first of all, probably many of those physicians that are in these other plans are in our network, I mean, because physicians are in multiple plans. But to the issue of if there is inadequate, let's say, specialty in one area, two things. One, if you have a private insurance program, you're going to have to travel to get that care because the providers are not there. Tricare has to pay for you to travel to get that care because we have a requirement to provide the care. So one of the issues that you're addressing is very real, but it's a ubiquitous issue that in certain rural communities, there aren't enough providers of a variety of specialties. But Tricare must pay for that beneficiary to travel, which is not true in other plans.
But is it possible that there might be a closer service provider in a different network other than yours, that perhaps they wouldn't have to travel quite as far?
And so conceivably that could be a case. And certainly for active duty and active duty family members, they can actually go and see those providers without the added cost. So for the retiree, they may have to get a waiver, basically, but we have a requirement to provide care. So either there or have them travel.
I thank you. I yield back.
Thank you, Mr. Chairman. I'm on healthcare on both sides, VA and DOD. And can you tell me, I know that the Veterans Administration would certainly like to do more DOD work. To what extent is that occurring?
Thanks again for that question. We, too, would like to do more business with the Veterans Administration. And as I mentioned before, we have a number of sharing agreements, and we're looking more closely how we can craft more mutually beneficial sharing agreements across the country. One of the interesting things that's happened with the rollout of the VA Choice product is that the way it was, I guess, outlined, it put in conflict our ability to, in fact, operate under the sharing agreements, and we're actually trying to unpack that right now and resolve those conflicts so that we can be at liberty to do more work with the VA.
Well, let me just say, I've had obviously problems with the VA in my district, in the building of a hospital that happened to be $1 billion over budget. And so during the process before, I didn't know whether I could get funding for it, and obviously we stripped the VA's ability to build another hospital again. But I remember going to the University of Colorado Health System and saying, would you take over this project and work with the VA and somehow purpose this for veterans? And I remember during those discussions that were occurring when I was concerned about not getting funding and what I was going to do with this half-built building, they said something very interesting. They said, you know what, we will not have VA employees in this hospital because we have two separate cultures and it would result in a separate standard of care. And I believe that the military medicine and the VA, I believe it's two separate cultures. And I'm very concerned. We need to reform the VA, but until it is reformed, I do, as a veteran of 21 military years of service, I don't want to see them taking care of our active duty, and I don't want to see them taking care of our active duty families, and I think that's absolutely important. And so I'm going to push back the other way. And in fact, we had flag officers from other branches of service that testified before us in an earlier hearing and essentially said the same thing. Different standard, two different cultures, different standard of care, and they were not supportive. And so I would ask you to relook at that, and I think I'm going to visit it for the National Defense Authorization Act coming up. It would be wrong for our military personnel to subject them to that system. I want to clean it up. We owe it to our veterans to do that, but until we do, it would be wrong. My father was in military medicine, and I can remember during Vietnam how that those soldiers that came home from Vietnam severely wounded were stabilized in the military system and were transferred to the VA for their rehabilitation. Thank God we don't do that right now. We keep our military personnel in the military system throughout the rehabilitation. Only if they opt for the VA do they go to the VA. And so I want to caution you on the direction that you're taking. Do you have a response to that?
No, I appreciate your concerns, and I appreciate your service and your certainly your commitment to ensuring quality care. We will take that under advisement. I think the issue is that we will be absolutely certain. Some of these sharing agreements have been in place for a while, but we'll relook at the quality of care in the organizations that we have the sharing agreements with.
Thank you, Mr. Chairman. I yield back.
Thank you. We'll continue with a second round of questioning. If you could, compare and contrast the differences between the military health system and its MTFs with civilian hospital systems and the best practices that are perhaps on the civilian side. I think you've alluded to some of them and how you try to increase capacity by increasing operational hours, increasing panel size, increasing productivity. How is that going to go? I mean, having worked in an MTF, certainly during my time there, we did not have a taxing schedule of patient flow. Whereas if you were in a civilian hospital, you were expected to see many more patients in the same period of time. And as we've heard, one of the issues that we hear from beneficiaries is the difficulty in getting an appointment slot. So I understand, you've alluded to implementing some of those things. How do you expect those to roll out? And what's the role of, is that being pushed by DHA, or does that have to be pushed by the Surgeons Generals? How does that actually get down to the MTF and implemented?
So the Surgeon Generals have a real role to play in this because under the current system, they actually operate the hospitals. But I think the issue is that the leadership with Admiral Bono and the Surgeon Generals have made it clear that we need to pivot to a full patient-centric, customer-focused delivery system. So in answer to your question about compare and contrast, there are many things that are the same. So we have to do hospitalization, we have to ensure access, quality, patient safety. We have to provide trained specialists. We have to organize and equip the hospital to provide those services and pay attention to all those metrics that are important. The contrast is, again, that the MTFs are medical force readiness platforms. They are soldier-focused readiness platforms, and the people who are in those MTFs tonight or tomorrow may be called to deploy somewhere in the world. And so there is going to be some difference in operations and maybe some cost to the efficiency. Now, you can rightly push back at me and say, well, what is that cost? And I wouldn't have an answer for you today, but I can tell you that that's what we're working on now to define what is the readiness cost so that we can produce the efficiency and the productivity to the highest level it can be at.
And I appreciate it, and I've said in just about every hearing that we've had on this issue that there is a cost to readiness, and we have to be ready to assume that cost if we want to have a ready deployable medical force and then a ready deployable combat force. So there's that intangible cost that the civilian sector does not have to deal with. But so transitioning to the readiness issue, as you just alluded to, as well as in your written testimony about how Tricare supports the readiness mission of the MHS with the military treatment facilities as a readiness training platform for medical forces. So how does DHA expand choice to the beneficiaries with their ability to choose either a military or civilian provider while making sure we recapture the right mix of patients to ensure that we do have that medically ready force? As you mentioned, incredible strides in combat casualty care, but we've also got to be ready to do the humanitarian mission and take care of that elderly patient with CHF in some far-off land. So how does DHA look at getting that patient mix?
Let me start the answer, and then maybe Admiral Bono can chime in. So the issue, again, at a basic level is we need to have good flow of patients through the hospitals to ensure that we keep the skills current. And that's not only for the docs, but it's for the nurses, it's for the OR teams, the medics, the x-ray techs, the pharmacy folks, the respiratory therapists. We need to have flow. And as you've indicated, that when we get into the fight, and particularly the medical fight, it's more than just trauma care. We actually have to take care of disease and non-battle injuries. And one of, again, our great statistics is a reduction in disease and non-battle injuries. So we need full-service platforms. Now, to answer your last question about the issue of the right flow, first of all, let me just pivot a little bit to PB17, because I think what we've done in PB17 is set a fee structure that encourages folks to use the MTF. We got to deliver on the customer care, the experience of care, clearly, but we set a fee structure that is the lowest cost option and incentivizes individuals to use the MTFs. But again, a lot of the detailed analysis relates to the geographic areas and what's available. So we can't put every subspecialist at every camp, post, and station, but we've got great centers and we've got great community hospitals that can be used more effectively. I don't know if Admiral wants.
I think just to piggyback on that, by making sure that the direct care system is the more attractive option, we incentivize patients to come in. But that also means that we need to be prepared to take them. And so working with the Surgeons General, we realize that we have to be able to make sure that it's easier for our patients to get in. And some of the things that we've also put in place are single pointing centers where the patient only has to call once. And also putting a first call resolution so that with that first call, the patient gets their appointment that they need. What we've also put in place is the nurse advice line, and this is something that we've implemented across all the MTFs with the services. And so patients can receive that advice from the nurses and be able to get some counsel on whether or not they need to go in to see somebody or whether they can take care of that. And then, of course, Dr. Woodson mentioned the asynchronous type of care through telehealth and secure messaging. All of that kind of combines to making sure that we have that capacity and that flow for our patients.
Thank you, Mr. Chairman. I know, Dr. Woodson, you responded to Mr. MacArthur in trying to, what would, is it even feasible to think about having an additional option for constituents? And I know that that was what the commission brought to us, and they were interested, and I think that you've done a good job of trying to lay out the piece as it relates to MTFs. I raise it just because I think that there might be a very small percentage of people that would have an interest in it. I can't imagine that there would be a great deal because it would be more costly. It should, no other constituent should subsidize that interest on the part of someone who perhaps has some special needs for some reason or other within the family, that they would choose to do that, just like people would choose more expensive options within, their company plan. Does that play a role somewhere? And I think partly what we're dealing with, of course, is always regions, and whether urban, rural, so that people don't always experience the same health care where they go, because it's a more limited ability of the community to respond, at least within a very short time span.
So thanks again for that question. So within the realm of possibilities, it's possible. The question is whether or not it's feasible and makes sense to do. Because here's the issue. Number one, you'd have to decide which benefits are going to be assigned to the health plan that they're going to get in the commercial market. So if you take the commission's outline, they had OPM setting up sort of a special exchange market where people could go and pick from 250 plans. But the Department of Defense was still responsible for dental, vision, pharmacy, and many other aspects of the program. And so there were going to be many more touch points than any beneficiary would have to coordinate on their own in order to get their full set of benefits. The biggest issue is what would be the incentive. So Tricare is a very robust, comprehensive benefit. We have the best autism coverage, bar none, in the country. The question is, who would go and pay now a $6,000, $7,000 premium with maybe total out-of-pocket costs of $9,000 as opposed to the $1,700 that exists today? And then what would be our responsibilities if they're not happy with that insurance product about coordinating their care? So the realm of possibility, yes. Feasibility for a small percentage, frankly, they have that right now. They can do that, right? Because all you have to do is not use your Tricare benefit, and you can buy a commercial product, or if your husband or wife works for an employer and they offer other health insurance, you can take that. So that option is there right now.
I wondered about that, and part of the I guess transparency of this may be that it's helpful for people to see that, even alongside the options that they have, so that they know that in fact they really are getting great care at certainly a reduced cost. And people, might know that. They might go on the net and see that, but there might be some reasons, and I guess it's just part of trying to say to people, we want you to be sure that you have all the information. And part of the process that we'll be going through is providing people with good information. So do you think that that would be information that would be important to people as in part of this education process? And I guess I know my time is up, how are we going to go about making sure that people do get good information so they can make those decisions?
So that's an excellent point. We need to communicate effectively. We can certainly make people aware that as things stand today, they can exercise their option not to use Tricare and buy commercial insurance and provide cost estimates so that they have a basis of comparison.
Yeah, that might be helpful to do. Okay, thank you, Mr. Chair.
Thank you. I'm going to actually continue that for a moment. I think we have to be careful when we talk about this, because in that discussion, I think we were conflating the Commission's recommendation of a private healthcare model with 250 plans with what I started with and what Ms. Davis started with, which was FEHBP, which is not a such an involved and dizzying, frankly, set of options. Personally, I don't think moving to a commercial system is advisable. I don't think it's necessary. And I was asking much more directed question about a single option, FEHBP, which is currently run by the federal government, and it includes many networks which have been less criticized, frankly, than the Commission certainly was of yours. So I think we have to be careful. And I also think complex systems are difficult to manage. You've got 9.8 million lives in Tricare. It's a $50 billion system. It's difficult to manage, and you've got the MTFs and the private contracts you have, but they're even more difficult to predict. And that's why I raised the question, because I don't know whether people would opt for it. I have no idea. All I know is the Commission was critical of the current networks, and I heard you, Secretary, that you have a large number of physicians in the network, 424,000, 5,000 hospitals, but this may be a problem of geography more than volume. You may have plenty of providers, I'm sure you do. The question is, do you have them where the beneficiaries have the need? It's hard to predict that, and that's why I ask about whether another option allows people to make that judgment for themselves instead of all of us trying to make it for them, which is impossible to do. That's a comment. I'm going to ask another question, though, and that's, Admiral, you mentioned the plan to go from 3 to 2 regions in Tricare, so I'm going to take a little different direction now. I'm always concerned that when we talk about change, we don't confuse motion for progress. And I'd like to ask you, why is 2 better than 3? These are still massive service providers. Now it just gets, each one gets even larger. How does that improve either service or cost?
With going from 3 to 2, and I think this is a great question and something that bears fleshing out a little bit. What we realized is we needed to be able to offer a more standardized benefit across all of our MTFs and across our services. And in looking at our geography and our current configuration where we had 3, we realized that we could already geographically work with 2 main contractors and be able then to kind of standardize and reduce some of the variability that we saw in having 3 plans. And so that was why we went ahead. We also looked at the overhead costs, not only within the contractors, but also within managing those from the DHA. And so we saw some great efficiencies by doing that, by going to 2.
I need you to be a little more specific, because economies of scale can be deceptive. You've already got massive scale in all 3 of your regions today. So what further economies do you expect to get out of just 2? Specifically, I mean, you can't unpack all of that, but give me 3, 4 very specific things that will be less costly in 2 regions than they are in 3.
Administrative process, setting up the contracts, 2 versus 3. You're going to have more standardized processes, easier flow as our beneficiaries move from one region to the other. We can standardize the automating process. We can standardize the communications to the beneficiaries and providers. We can leverage the use of their data systems without having to go to more data systems to do population management, quality management. So there are actually multiple benefits to moving to.
Then if that's true from 3 to 2, why not go to 1?
Well, that's a good question. I think it's about the issue of risk if you put all of your eggs into one basket, but that's a good question. But I would also make this historical note. You know, we didn't arrive at this overnight. Remember, there was a time when we had 12 and then 6 and then 4, and so we've been progressively getting here. The ability to coordinate when you have 4, 5, 6 contracts is just a nightmare. The updates in the manual, when these contracts roll out, so they're always at a sequence. Administratively, it's just a lot easier.
I'd stay all night if I could, but my time has expired. Thank you.
Thank you. I got one last question because I didn't see it addressed in PB 17. The fate of Tricare Reserve Select. So what happens to reserve members? Are they going to be moved into either a Tricare Choice or Tricare Select plan, or do we maintain TRS?
So as a product, it will be Tricare Choice. But I think the larger question you're asking has to do with what are the optimum products for the reserve components. And that is really under study because there are a couple of different, well, there are several different solutions that might be applied to the reserve component. The real issue with the reserve component is that when they're mobilized, how do you prevent turbulence in terms of families having to switch doctors and insurance plans? The answer for the reserve component might be one of several options. One would be if everybody took Tricare Reserve Select, or now Tricare Choice, they would have that PPO product and then they could use, and of course the member comes on active duty and nobody has to change doctors. Another solution might be something similar to the commission recommendation, which is to give BAHC when the reservist comes on active duty, and then they don't have to switch their insurance plan, but you just give them a basic allowance for health care. Another solution might be to offer Tricare Choice into the employer insurance plans, which might work for the employer and might work for the reservist because it might be a lower cost option and get greater acceptance of Tricare Reserve Select. So there are many options, and we need to really poll and assess the reserve community about what they're doing for insurance now, what the options are, because we don't have the right answer. We don't have enough data to make the right answer now.
I appreciate that. Three very great options, I believe. Do you believe that you'll have data in time to make a suggestion through this NDAA process that's going to probably wind up before June?
We will not have enough data for this cycle. We certainly will have for the next.
Okay, I appreciate that. Again, I thank both of you for being here so long at this late hour and answering the questions as effectively as you did. There being no further business, I will adjourn the subcommittee.